Welcome to the Deep Dive, the show that takes foundational concepts, the ones you think you know, and really just cracks them wide open to reveal the astonishing complexity underneath.
And today, we are doing just that.
We are undertaking a really detailed deep dive into the absolute cornerstone of clinical audiology, the pure tone evaluation. You know it as the standard hearing test.
It really is the test that most of us remember taking in school. You're sitting in a quiet room, you're waiting for that faint little beep.
Yeah, and you're trying to figure out, did I actually hear that, or did I just think I heard it?
Exactly. And we see it in pop culture all the time, right? Whether it's the simple screening they do in a film like Hannah and Her Sisters, or even its tactical use in Wind Talkers.
But that casual screening experience, that really undersells the whole procedure. I mean, the pure tone, or PT threshold test, is not some simple game of just pressing a button.
Oh, not at all. It is a highly sophisticated diagnostic tool. And its proper administration, and maybe even more critically, its interpretation, it requires a really deep understanding of acoustics, of psychophysics, and pathology.
So our mission today is to go far, far beyond that initial beep. We've synthesized a whole range of extensive sources covering the methodology, the physics, and the clinical application of PT testing to show you exactly why it's so essential.
If you want that comprehensive, that detailed understanding of hearing assessment, this is pretty much it.
In this whole process, it's all about determining the absolute lowest level of response to a simple tonal stimulus. But to really appreciate what that threshold means, we had to start at the very beginning.
Okay, let's unpack this, starting with the absolute fundamental building blocks of sound itself. What even is a pure tone?
Right. So when we talk about sound in the physical world, what are we even talking about? We're talking about waves, and those waves have specific, measurable qualities.
Exactly. And for audiometry, we use pure tones because, well, they are the simplest sound waves you can create. A pure tone is defined by four things: frequency, amplitude, phase, and duration.
But for our clinical purposes, it's really frequency and amplitude that are the heavy hitters, right?
They're the ones that matter most. Frequency, which we measure in hertz or hertz, is what our brain perceives as pitch. It's what determines if a sound is a low, deep rumble or a high, piercing whine.
And the range of human hearing is just, it's massive.
It is. If you're a young person with completely normal hearing, your auditory system can theoretically process sounds from 20 hertz, which is a rumble you almost feel more than hear, all the way up to 20,000 hertz, a piercing squeal.
But, and this is a really interesting physiological insight, we are not equally sensitive across that entire 20 to 20,000 hertz range.
Not even close. We're actually much, much better or more sensitive at hearing sounds in the middle range, roughly between, say, 500 hertz and 8,000 hertz.
So what does that mean in practical terms? It means we need significantly less physical energy to perceive a tone at 3,000 hertz than we do at, say, 100 hertz.
Precisely. And this is why conventional pure tone audiometry concentrates its efforts on that specific range, from 250 hertz, sometimes even 125, up to 8,000 hertz.
Because that range is vitally important. It aligns almost perfectly with the frequencies that are absolutely critical for understanding human speech.
Yes, which typically falls between about 100 hertz and 6,000 hertz. If you can hear well in that core band, you can communicate effectively. It's as simple as that.
Okay, so that's frequency. Now let's pivot to amplitude, the intensity, the loudness of the sound. This is quantified in decibels, or dB, and this is where the conversation moves from simple physics to, well, to clinical necessity.
And this is where it gets tricky. Decibels are inherently a little confusing because they are a logarithmic ratio. They are, and this is the key, completely meaningless until you establish a reference point.
So they don't measure pressure directly. They measure how one pressure relates to another.
Exactly. If someone just says it was 80 dB, your immediate question has to be 80 dB reference to what?
And in audiology, we use two primary references, which can really confuse anyone looking at the field for the first time. There's dB sound pressure level, or SPL, and dB hearing level, or HL.
Let's start with dB-SPL. This is the physical standard. Its reference point is fixed. 20 micropascals, a tiny, tiny unit of pressure.
And why that specific number? 20 micropascals.
It was specifically chosen because it represents the absolute faintest pressure that the most sensitive part of the human ear can just barely detect. It's effectively the absolute zero of sound pressure perception for us.
So the crucial point about dB-SPL is that its reference is constant. It's the same across all frequencies.
Right. If you're comparing a tone measured at 60 dB-SPL at 500 hertz versus one at 60 dB-SPL at 8,000 hertz, they have the exact same physical sound pressure hitting the eardrum.
And we use SPL all the time in audiology, right? For measuring speech levels, levels or environmental noise.
Or to calculate the actual physical output of a hearing aid speaker. And if you're graphing sound in SPL, the plotting is very intuitive. Higher numbers mean louder sounds, and they sit higher on the graph. Simple.
But then we move to the clinical scale, the one we use for the audiogram, and that's dB hearing level, or dBHL, and this is the great equalizer.
It is. So we already established that the human ear naturally hears those mid-frequencies better than the very low or very high ones. If you were to plot the absolute physical pressure the SPL required for a young, normal ear to just barely hear a sound across all frequencies, you would get what's called the minimum audibility curve.
And that curve looks like a giant dramatic U.
A giant U.
Yeah.
You need a huge amount of pressure, a very high SPL value to hear the low frequencies. Then you need less pressure in the middle, and then you need more pressure again to hear the highest frequencies.
So dBHL is designed to fix this physiological variance.
Precisely. The zero reference level for dBHL varies with frequency, specifically to flatten out that U curve. At every single frequency, 0 dBHL is defined as the median threshold for young, normal hearing adults.
So the aha moment for you, the listener, is really understanding this difference visually. If you plot a normal ear's ability on an SPL graph, it's a U curve. But if you plot it on the clinical audiogram using dBHL,
the normal range becomes a straight, flat, honestly kind of boring line right across the top at 0 dBHL. We've normalized out that physiological difference.
And that standardization is incredibly powerful because a threshold that's plotted at, say, 40 dBHL at any frequency tells the clinician immediately this person needs 40 decibels more intensity than the average young adult to hear this specific frequency.
It represents the degree of deviation from normal. It's all about comparison.
And this leads us to what is probably the most confusing plotting convention in all of audiology, that poor hearing is plotted down. Larger values in dBHL, which mean more hearing loss, are placed lower on the audiogram graph, moving down toward the bottom axis.
Right. We plot severity, not physical intensity. You really have to flip your intuition around when you're looking at that chart for the first time.
Okay, so we've defined the tone, but let's circle back to that central question. Why are we using these simple, isolated beeps when real-world listening involves complex, constantly changing speech? Why not just test speech comprehension from the start?
It's the most logical question a person can ask. I mean, it seems so obvious. But the reason we rely on pure tones is all about their diagnostic specificity. They give us information that speech measures, as useful as they are, simply cannot.
And there are two main reasons for this.
Two primary interconnected answers, yes. The first is about quantifying and, crucially, separating the type of loss. So a patient comes in, they say they hear speech poorly. Okay. Is that a mechanical problem in the ear canal or the middle ear? Or is it a nerve problem in the cochlea or the brain?
Two totally different problems with totally different treatment.
Totally different. And pure tones are the only tool that can rigorously separate those two possibilities. We use the comparison between air conduction, or AC, where the sound travels through the entire ear system, and bone conduction, or BC, where we bypass the outer and middle ear entirely by vibrating the skull.
And that comparison, AC versus BC, that's the fundamental key to diagnosis.
It tells us precisely how much of the loss is conductive, meaning outer or middle ear, and how much is sensorineural, which is the cochlea or the nerve. Without that separation, any treatment, whether it's medical intervention or fitting hearing aids, is really just a guess.
And the second reason is pure, beautiful frequency specificity. Damage in the auditory system is rarely uniform across all frequencies. It's almost always localized.
Exactly. Just think about the physics of the middle ear. Our sources note that changes in middle ear stiffness, often from fluid, like in an ear infection, affect the low frequencies much more significantly.
Whereas an increase in mass may be due to an issue with those tiny little bones, the ossicles, that tends to hit the high frequencies harder.
Right. And this isn't new information. This relationship was noted way back in 1948, and it absolutely holds true today.
But the specificity goes even deeper, doesn't it? Into the inner ear itself. We have to talk about tonotopic organization.
We do. This is the frequency-to-place mapping that exists throughout the entire auditory pathway. The basilar membrane inside the cochlea is physically tuned, just like a miniature piano.
So different parts of it respond to different notes.
That's a perfect analogy. The base of the cochlea, which is the narrow, stiff end, it responds to high frequencies. The apex, the wide, floppy end at the very center of the spiral, responds to low frequencies.
So when we present a pure tone at, say, 4,000 hertz, We are aiming that sound, that diagnostic beam, at a very specific tiny group of hair cells at the basal end of the cochlea.
Exactly. So if we find a hearing loss only at 4,000 hertz, we know the damage is localized to that precise area. If we only used a broadband stimulus like speech, which spans hundreds of frequencies all at once, that tiny specific patch of damage would be completely masked by the responses from all the healthier adjacent cells.
Pure tones let us pinpoint the damage. They let us understand the etiology, the cause.
And beyond this core diagnostic function, PT thresholds are really the bedrock for almost every subsequent clinical decision we make.
For example, they're used to estimate the degree of hearing handicap, though, as we'll discuss, that estimate can be a bit imperfect.
Yes, but more practically, they establish the essential baseline measure for any hearing conservation program. You simply cannot track noise damage over a worker's career if you don't have a reliable, frequency-specific baseline to start from.
They're also crucial for monitoring changes, maybe due to a disease progression like the fluctuating loss in Meniere's disease, or for tracking potential damage from ototoxic medications.
They determine candidacy for hearing aids or cochlear implants, and they guide the audiologist in setting the frequency gain characteristics of those devices. I mean, if the high frequencies are profoundly lost, the hearing aid needs to focus its amplification elsewhere. There's no point in amplifying a dead region.
And finally, they provide the necessary reference for almost every advanced audiology test we perform. That includes suprathreshold speech testing, which is testing speech understanding at a comfortable listening level, as well as objective tests like otoacoustic emissions or acoustic reflex thresholds.
Right. Without accurate PTs, the rest of the diagnostic puzzle it falls apart.
Okay, so the history of hearing testing starts with some pretty rudimentary tools. Before we had electronic audiometers, clinicians were using tuning forks.
Right, and they provided qualitative insights. Not quantitative, but qualitative. They could give you a rough idea if a loss was conductive or sensory neural.
A tuning fork, when you strike it, it produces a sustained, fairly pure tone. They're uncalibrated, so you don't know the exact decibel level, but they allowed for a quick and dirty comparison of air and bone conduction.
And the two famous tests here are the Weber and the Rinn. In the Weber test, you place the fork on the patient's forehead, and the listener reports where they hear the sound, which ear hears it.
And the results can be a little counterintuitive.
They can. If the loss is conductive, the sound lateralizes to the poorer ear. And that seems strange, but it's because the conductive loss is actually blocking out ambient room noise from reaching the cochlea on that side, which makes the internal bone-conducted sound seem more prominent.
But if the loss is sensory neural, it lateralizes to the better ear, because the damaged cochlea just can't perceive the sound ever well at all.
Then you have the Rinn test, which compares the perceived loudness of air conduction versus bone conduction. You place the fork on the mastoid bone behind the ear, and then you hold it near the ear canal.
And in a conductive loss, the sound is louder when it's delivered by bone conduction because you're bypassing that middle ear blockage.
Whereas in a normal ear or one with a sensory neural loss, air conduction is always louder.
But while these are historically significant, the sources are really clear on their limitations.
Oh, very clear. They're often just plain inaccurate. The Rinn test, for example, it misses about 50% of conductive losses that have air bone gaps as large as 20 dBs.
That's a huge margin of error.
It is. So the takeaway here is crucial. Tuning fork tests are not a replacement or even a useful supplement for modern audiometry. High-quality audiometry can identify nearly 100% of air bone gaps as small as 15 dBs. We have to rely on the precision of calibrated equipment.
Which brings us to the modern instrument, the audiometer. This machine is the technological core of the clinic. It's responsible for generating, selecting, and routing the pure tones at very precise intensities.
ANSI defines 4 types, ranging from the Type 1 full diagnostic machine, which can do everything, including extended high frequencies and complex masking, all the way down to a simple Type 4 screening device.
Now, we need to acknowledge a major physical constraint when we're talking about this equipment, and that's the maximum output level. A diagnostic audiometer can present air conduction tones up to 120 dBHL in the mid-frequencies, but for bone conduction, that maximum output is drastically lower.
That's right. The maximum BC output can be nearly 50 dBH lower than the AC limit. People always ask, why is that? It's a fundamental physical...
It's not just a design choice.
Not at all. The bone vibrator works by physically vibrating a small area of the mastoid. If you try to push that vibrator to extremely high intensities, the signal itself becomes distorted. It starts producing harmonics and noise that are not pure tones, which completely invalidates the test.
And it also just starts vibrating so violently that it lifts off the skin, right?
Yes, which also limits the effective transmission of energy. That 50 dB difference is why BC testing is so challenging when you're dealing with severe losses. The equipment simply runs out of dynamic range before we can confirm the true sensory neural reserve.
But the diagnostic power still rests on that core comparison. Air conduction versus bone conduction. AC tests the entire system via earphones. BC tests the inner ear directly via vibrator.
And we get those 4 key patterns. Normal hearing, where AC and BC are both normal. Conductive loss, where AC is impaired but BC is normal. The problem is in the outer or middle ear.
Sensory neural loss, where AC and BC are equally impaired. The problem is in the cochlea or the nerve. And mixed loss, where AC is impaired, BC is impaired, but AC is still poorer than BC.
And those 4 categories, they inform probably 90% of all treatment planning in audiology.
The evolution of the transducers, the things that actually deliver the sound, is a really fascinating study in just optimizing clinical results. For years, the traditional standard was the supraoral earphone, like the old TDH-49s, which rest on the ear flap, on the pinna.
They're easy to calibrate, which is a plus, but they have some major drawbacks which led to the rise of the insert earphone, like the ER3A, which uses a little foam plug that goes deep into the ear canal.
And the advantages of the insert earphone are pretty significant.
They are. The most crucial one is the increased intraoral attenuation, or IA. IA is simply the amount of sound reduction that happens as the signal crosses the head to reach the non-test ear. With supraoral phones, the IA is about 40 dB.
But with inserts, it increases by approximately 20 dB.
Right, so if I'm testing the right ear and I present a tone at 60 dB HL with standard headphones, about 20 dBs of that sound might leak across to the left ear. With insert phones, almost no sound crosses.
And why is that so important?
It dramatically reduces the need for masking the non-test ear. When you can eliminate that cross-hearing earlier, you save a significant amount of time. But more importantly, you decrease the occurrence of something called a masking dilemma.
Which happens in really severe bilateral losses.
Exactly. It's where the required masking noise in the non-test ear is so loud that it actually crosses back over and interferes with the ear you're trying to test. Inserts really help mitigate that problem.
Plus, they eliminate the potential for collapsed ear canals, which is a physical compression of the canal caused by the traditional ear cup that can falsely indicate a high-frequency hearing loss.
And they're fantastic for infants and toddlers. But they do have limitations. They can't achieve the maximum output levels of supraoral phones, and they can yield unreliable low-frequency results if the eardrum is perforated, due to calibration issues.
And of course, those disposable foam tips cost money. They introduce supply chain considerations that a clinic has to manage. So really, a modern clinic needs both types of transducers.
Yes, and sometimes more. We also see specialized circumaural earphones, which surround the ear. Those are used specifically for testing extended high frequencies, up to 20,000 hertz, which is absolutely crucial for monitoring for ototoxicity.
Now, beyond headphones, sometimes we have to use speakers to generate what are called sound field thresholds. This is often necessary when we're testing babies or maybe verifying how well a hearing aid is working.
But sound field testing requires extreme caution because you immediately lose ear specificity.
Meaning the threshold you get is always determined by the better hearing ear. You have no way of knowing if the right ear or the left ear actually heard the sound.
That's right. And furthermore, the physics of a room are incredibly complicated. Pure tones in an open space create standing waves. This means the intensity of the tone can vary wildly depending on where the listener is located.
So just moving your head a few inches could change the sound level at your eardrum by 20 dBs or more.
Easily. It's a huge source of error. And to combat those standing waves, audiologists avoid using pure tones in the sound field. Instead, they prefer frequency-modulated tones, also known as warbled tones.
And these tones vary slightly in frequency, just a few times per second.
Exactly. And that frequency variation prevents a stable standing wave pattern from ever forming, which provides a much more consistent and accurate intensity level across the entire listening area.
And finally, the environment itself is a critical variable. Testing has to adhere to these strict ANSI guidelines for maximum permissible ambient noise levels, which often requires a sound-treated booth.
Ambient noise is a huge threat to validity particularly for bone conduction, where the ears have to remain uncovered. And if circumstances force you to test in a noisy hospital or a nursing home, which has to be clearly documented, insert earphones are strongly preferred because they provide superior low-frequency attenuation against all that external noise.
Okay, so now we get to the actual clinical procedure. This is really where the physics meets human behavior. The goal is to define the auditory threshold, that exact point where sound perception begins. And this whole process is rooted in the field of psychophysics.
Right. Psychophysics is the study of how physical stimuli, like a decibel level, relate to psychological or behavioral responses, like saying, "I heard it." And the clinical procedure we use is a specific technique called the modified method of limits. The tester controls the stimulus, and the patient reports their perception.
And the very first step is the instruction. And this is surprisingly crucial. Instructions have to be given before the earphones are placed on the patient.
Yes. And why is that? It's because the earphones themselves already introduce 20 or 30 D lines of attenuation. It makes it very hard for someone with a pre-existing loss to even hear your instructions clearly once they're on.
The instruction has to explicitly tell the listener to respond anytime they hear the tone, no matter how faint it may be. And this is designed to control for response bias.
It is. If the patient anticipates the tone will be loud, or if they wait until they are 100% sure they heard it, their thresholds will be artificially elevated. You'll get a false indication of hearing loss. We want a true measure of their minimum auditory capability.
Once that's understood, the transducers are placed, red for right, blue for left. And the audiologist has to ensure proper coupling, whether that means centering the supraoral cushion or ensuring the insert foam plug is deep enough to get the full benefit of that intraoral attenuation.
For bone conduction, about 92% of clinicians prefer using the mastoid process. That's the bone directly behind the ear. This placement yields thresholds that are 8 to 14 dBs lower or better than placing the vibrator on the forehead.
So even though the forehead provides slightly less variability between tests, the mastoid is chosen because it allows for the lowest possible threshold measurement before hitting the equipment's limits.
It maximizes the diagnostic range. The actual testing sequence usually begins in the self-reported better ear at 1,000 Hz. And the starting level is often 30 dBHL.
And why 1,000 hertz?
Because that frequency generally has the best test-retest reliability. And the patient is most likely to hear it easily, which provides a quick, positive familiarization with the task.
Let's talk about the tone itself. Clinically, we prefer pulse tones, typically something like 225 milliseconds on, 225 milliseconds off.
Patients generally prefer them, but the reason they're clinically superior is because they help in managing tinnitus.
Right. Tinnitus, that internal ringing or buzzing, is a continuous sound.
It is. So if you present a continuous test tone, a patient with tinnitus might struggle to distinguish the external signal from their internal noise. They might give you false positive responses. A pulse tone is distinct. It helps the listener separate the signal from their continuous internal noise, which improves test accuracy.
And now we get to the cornerstone of the whole behavioral procedure, the Hewson-Westlake procedure, which employs the famous down 10 up P5 rule.
This rule is often stated simply, but understanding why this specific combination of steps works is really the key psychophysical insight.
So walk us through the mechanism. Why is this down 10 up P5 rule the secret sauce for getting reliable results?
The procedure is specifically designed to sneak up on the patient's threshold from below the level they can hear. So we start with a clearly audible tone, say at 30 dBHL. Once they respond, we drop the tone by a large step 10 dB. They still hear it, we drop it again, and we keep dropping by 10 until they stop responding.
So we've established the ceiling of their hearing.
Exactly. Then, when they fail to respond, we raise the tone by a much smaller step, only 5 dB. And this down 10 up P5 asymmetry is genius. The large 10 dB decrease quickly moves the stimulus into the inaudible range, which minimizes anticipation. Then the small 5 dB increase carefully guides the level back up, confirming the actual threshold with maximum precision.
It's all about controlling that moment of uncertainty.
It is. So the threshold is officially defined as the lowest level at which the listener responds for 2 ascending runs. That means 2 separate times when the tone went from below their hearing level up in 5 dB steps and they clicked the button.
And once 1,000 hertz is established, and often remeasured just for reliability, we proceed with the frequency progression.
We test the octave intervals, 200, 500, 1,000, 2,000, 4,000, and 8,000 hertz, plus the really important intermediate frequencies of 3,000 and 6,000 hertz, because those are so sensitive to noise damage.
And we also need to remember the 20 dB rule. If the thresholds between two adjacent octave frequencies differ by 20 dBs or more, the audiologist has to test the inter-octave frequencies, like 750 Hz or 1500 Hz.
And why? Because a sharp drop-off in hearing can hide really important diagnostic information between those measured points. You have to fill in the gaps.
And all of this leads us to the crucial complication, masking. As we discussed, sound can cross the head to the non-test ear, which can make the results completely invalid.
So we use masking noise, a specific type of narrowband noise, to eliminate the non-test ear's participation in the test.
And this is often the hardest part of the test for the patient. They're hearing the signal in one ear and this rushing static-like noise in the other. How do we know when we need to mask?
We use the integral attenuation number. For air conduction, using standard supraoral phones, we have to start masking when the difference between the AC threshold of the test ear and the best possible bone conduction threshold of the non-test ear is 40 dBs or more.
So if the sound is presented at 40 dBs above the non-test ear's BC ability, we just assume it has crossed over and is being heard by the good ear.
We have to assume that. And if we use insert earphones, that threshold difference goes up to about 60 dBs. That 20 dB increase in IA makes a huge difference in avoiding complex masking protocols. It reinforces why they're superior tools for these complex losses.
Masking really is the difference between getting a valid ear-specific result and getting a misleading result that's just being dictated by the better ear.
It is the art of clinical audiology.
So once we have all of those precise thresholds, they're plotted on the audiogram. This is the foundational clinical document. It's a graph that visually represents the PT thresholds with frequency on the x-axis and intensity in dBHL on the y-axis plotted upside down.
And the standardization of symbols is absolutely vital for professional communication. AC thresholds are plotted with an O for the right ear in red and an X for the left ear in blue. BC thresholds use the chevron symbols, a less than sign for the right, a greater than for the left. And mask symbols involve triangles, squares, or brackets.
The first step in interpretation is to classify the degree of loss, or the severity. This is typically done using the pure tone average, or PTA, which is derived from the average of the air conduction thresholds at 500, 1000, and 2000 Hz.
The severity classification categories, normal, slight, mild, moderate, severe, profound, are all based on this PTA. However, it's really important to note that the boundaries are not universally fixed. Our sources show that the upper limit for normal hearing can vary. Some authors suggest it's less than 16 dTHL, others say less than 26 dBHL.
That variance really highlights the evolution of clinical standards over time. But the profound category is fairly consistent. Greater than 90 dBHL is widely accepted as the quantitative and qualitative boundary between having some hearing and functional deafness.
Now, let's go back and address the flaw you mentioned earlier, the PTA's ability to estimate handicap. The PTA was initially intended as a quick predictor of speech understanding, but it's only somewhat successful.
Right. If two people both have a PTA of 40 dBHL, they are both classified as having a mild to moderate loss. But what if one person has a flat 40 dB loss across all frequencies, and the other has a 20 dB loss at 500 Hz, but a steep drop to a 60 dB loss at 4000 Hz? They have the same PTA, but they have completely different real-world communication issues. So isn't the PTA fundamentally limited?
Absolutely. It's fundamentally limited because it only uses 3 frequencies and it completely ignores the configuration, the shape of the loss. Speech understanding relies on a much broader range, up to 6000 Hz. And critically, distortion factors in the inner ear are completely ignored by the PTA.
So it's a good screening metric.
It's a good screening metric, and it's a useful validator for the speech reception threshold, which we'll get to. But it should never, ever be the sole measure of disability.
Okay, so the second and perhaps most vital layer of interpretation is the type of loss, which is determined by the presence and the size of the air-bone gap, or ABG.
We use a simple rule for this. If the difference between the AC threshold and the BC threshold at any given frequency is greater than 10 dBp, that indicates an air-bone gap, and therefore a conductive component to the hearing loss.
So a pure conductive loss means the AC is poor, but the BC thresholds are completely normal. The sound is just blocked mechanically in the outer or middle ear, but the inner ear is perfectly healthy.
A pure sensory neural loss means the AC and BC thresholds are equally impaired. They both fall outside the normal range. There's no significant gap. The inner ear or the nerve is the site of the damage.
And a mixed loss shows an air-bone gap, which proves a conductive component exists, but the BC thresholds themselves are also outside the normal range, confirming there's damage in both the mechanical and the neurological parts of the system.
And interestingly, our sources confirm that the maximum physiological air-bone gap you can actually achieve is only about 65 dBs. It's a limit imposed by the physics of how a damaged middle ear still allows some energy to transmit to the cochlea, even when it's severely blocked.
Finally, we analyze the configuration or the shape of the audiogram, and this is often a direct fingerprint of the cause of the loss.
These configuration categories provide critical etiological clues. A flat loss, for instance, with less than a 5 dB rise or fall per octave suggests a uniform problem, maybe related to certain types of otitis media. A rising configuration where hearing is better in the high frequencies, that's the classic early sign of Meniere's disease.
And we look for the different slope types: gradually falling, sharply falling, and precipitously falling. The faster the drop, the more acute the damage profile.
And of course, the highly diagnostic notched configuration. This is defined by a 20 dB or greater loss at a single frequency, often 4,000 Hz, with a recovery at the adjacent frequencies. This is the visual signature of noise-induced hearing loss. The configuration can tell you the entire medical history in just one glance.
And we also classify bilaterality. Is it unilateral in one ear or bilateral in both? And if it's bilateral, is it symmetric, meaning equal loss, or asymmetric, meaning there's a significant difference? That asymmetry is one of the most important red flags we plot.
A huge red flag.
As sophisticated as pure tone evaluation is, it is still a behavioral test. It's reliant on human responses, and because of that, it is inherently imperfect. We have to address the issue of test-retest variability.
We do. We rarely get absolutely identical results on repeat tests. It just doesn't happen. The variability stems from the patient's own biological noise, shifts in their response criterion. They might be more cautious one day than the next, and even subtle differences in how the transducer is placed.
And this inherent imprecision is what causes those occasional false air-bone gaps, or even false bone air gaps, which can lead to a misdiagnosis if the clinician isn't being cautious.
Let's try to quantify the problem. If we assume a 5 dB standard deviation for a threshold measurement, meaning about 68% of people tested will be within 5 dBs of their true value, the chance of a single frequency threshold differing by 15 dBs or more on retest is pretty low, but 1.24%.
But when you expand this to a complete audiogram, say measuring 6 frequencies in 2 ears, the probability just skyrockets.
It does. Our sources note that 14% of people tested will show at least one threshold differing by 15 dBs or more across that full assessment. What that means is that large, isolated differences are actually quite common, not rare, in the clinical setting.
So because of this reality, defining a significant threshold shift requires criteria that account for this variability. You can't just react to every 5 dB change.
Right. OSHA, for example, defines a shift as a 10 dB or greater change in the pure tone average for 2, 3, and 4 kHz in either ear. ASHA suggests that two adjacent thresholds have to differ by 10 dBs or more on retest to be considered significant.
Moving on to another key limitation, especially in cases of severe hearing loss: vibrotactile thresholds. When the sound is very, very loud, we may not be hearing it, we may just be feeling the vibration.
This phenomenon, perceiving sound through touch, is especially relevant for bone conduction testing at low frequencies, specifically 250 and 500 Hz. The physical stimulus required to induce a vibrotactile sensation is surprisingly low at these frequencies.
So imagine a patient with a profound sensorineural hearing loss. If we present a 70 dB HL tone at 250 Hz, they may not actually hear it, but they might feel the bone vibrator buzzing their mastoid. They report a response, but it's a tactile response, not an auditory one.
And this causes a very predictable error. A false air-bone gap will appear at 250 and 500 Hz because the BC thresholds are artificially depressed by that tactile perception. This has to be differentiated clinically, often by just asking the patient directly, are you hearing that or are you feeling it? It relies heavily on clinical judgment.
We also need to recognize that bone conduction, even though it's designed to isolate the inner ear, is not always pure. The middle ear can, in fact, influence BC thresholds.
The classic physiological example of this is Carhart's notch, which occurs in patients with otosclerosis. This disease causes the stapedium bone to become fixed in the oval window, and this fixation affects the normal inertial movement of the ossicles that occurs during bone conduction.
So because that normal inertial response is lost, the BC thresholds appear to worsen. They create a notch, which typically peaks around 2,000 Hz by about 15 dB.
And the fascinating part is that this notch disappears completely after a successful surgery to treat the otosclerosis. This proves that it was a mechanical middle ear phenomenon influencing the bone conduction result, not actual damage to the cochlea.
It's a conductive component masquerading as a sensory neural issue right on the BC line.
Exactly. And we can also see the reverse. Enhanced BC thresholds. This can happen in low frequencies in certain pathologies, like otitis media with effusion, where BC thresholds can be falsely enhanced by up to 25 dBs, making the hearing look artificially better than it actually is.
And of course, the most common factor that causes low-frequency BC enhancement is the occlusion effect.
This is just simple physics. If you close off the external ear canal, say, with the supraoral headphone cup, the low-frequency energy generated by the bone vibration gets trapped and amplified in the canal.
Which is why that deep placement of insert earphones is preferred, as it minimizes the occlusion effect because the foam plug is beyond the bony cartilaginous junction, which is where the effect is most pronounced. The clinician has to constantly manage these factors, particularly during the critical phase of masking.
It's a constant balancing act.
The real power of the pure tone test lies in its ability to translate a complex disease state into a simple, recognizable visual pattern on the audiogram. So let's look at how these configurations act as diagnostic fingerprints.
Okay, let's start with the two most common. Presbycusis, which is age-related hearing loss, is characterized by a high-frequency sensorineural loss, a gently sloping pattern. This is the result of cumulative damage over time, and it typically starts in that basal, high-frequency region of the cochlea.
And the most recognizable pattern we mentioned earlier, noise-induced hearing loss, or NIHL. This is that distinctive notch, often maximized at 4,000 hertz or 6,000 hertz.
And this localized damage is often attributed to the resonant frequency of the ear canal itself, which acts like a natural amplifier. It boosts sound pressure in that critical 3 to 6 kilohertz range by as much as 20 DEDs, causing a localized mechanical failure of the hair cells.
And this pattern can also hold clues for specific acoustic trauma, right? Like the loss pattern being predictably worse in the ear that's closest to a firearm muzzle.
Exactly. Pure tone evaluation is also vital for screening high-stakes, low-incidence conditions like acoustic tumors, also called vestibular schwannomas.
These tumors are rare, but it's critical to catch them early. They grow on the auditory nerve, and because the nerve fibers that carry high-frequency information are located on the outside of that nerve trunk, the tumor often causes pressure and damage to those high frequencies first.
So the resulting audiogram frequently shows a unilateral or asymmetrical high-frequency sensorineural hearing loss.
And the PT test acts as a superb, very cost-effective screening tool before you have to resort to an expensive MRI.
It does. By calculating the average threshold difference between the two ears for the frequencies 1, 2, 4, and 8 kilohertz, an audiologist can flag potential patients. A difference exceeding 15 or 20 dBs between ears maximizes the identification of potential tumors while drastically minimizing false positives. Though we must always remember that nearly 3% of cases show no asymmetry at all.
For Meniere's disease, which involves that trio of fluctuating hearing loss, dizziness, and tinnitus, the pure tone test helps track the progression of the disease.
Meniere's often begins as a unilateral sensorineural loss, and the configuration is often a peaked audiogram, where the loss is greatest in the low and high frequencies, with better hearing in the mid frequencies. It can also present as a rising audiogram in the very early stages. Monitoring those PT thresholds is essential because the loss characteristically fluctuates.
In hospital settings, monitoring for ototoxicity damage from certain drugs like chemotherapy agents or powerful antibiotics is paramount. Since the damage usually begins at the basal end of the cochlea, which codes those high frequencies, the testing is pushed to its absolute limit.
We strongly recommend extended high-frequency testing up to 16,000 or 20,000 hertz for early identification. If we see a threshold drop at 14,000 hertz, we can alert the prescribing physician to potentially switch medications before the damage encroaches on the critical speech frequencies below 8,000 hertz.
Switching gears to the most common diagnosis in children, otitis media with effusion or fluid in the middle ear. This causes a mechanical conductive hearing loss.
And the PT signature is a fluctuating conductive loss, typically between 0 and 40 dBs, averaging around 25 dBs. The pure tone test quickly identifies the presence and the degree of the fluid, which prompts the appropriate medical referral.
We also have to circle back to the complexity of tympanic membrane perforations. A perforated eardrum means a significantly increased volume of air in the middle ear space.
And this pathology creates a severe challenge for specific transducers. Low-frequency thresholds obtained with insert earphones can be 15 to 25 dBs poorer than those obtained with supraoral earphones. And why is that? It's because the calibration of the insert earphone relies on a standardized small volume of air in the ear canal.
But when the canal volume dramatically increases because of a perforation, the insert earphone under-pressurizes the system, which leads to falsely depressed thresholds.
That's right. In these specific cases, the supraoral results are often more reliable and more accurate.
And finally, we just have to acknowledge the complicating factors in interpretation. Tinnitus, as we discussed, requires the careful use of pulsed tones to avoid false positives.
Pseudohypoacusis, or non-organic hearing loss, is flagged by poor test-retest reliability, significant inconsistency in responses, and a tendency for thresholds to inexplicably worsen during the test procedure. The PT thresholds are a critical component for validating the patient's effort.
And in auditory neuropathy, where the problem isn't hearing sensitivity but the timing of the neural signal, PT thresholds can range from normal to profound. But the hallmark is the very inconsistent and often contradictory behavioral audiometric responses, even if they have severely compromised speech recognition.
It's a real diagnostic puzzle.
We return now to the connection between that simple pure tone and the complex, meaningful world of speech. Pure tone thresholds are used to validate and inform all subsequent speech testing.
The classic validation test involves the speech reception threshold, or SRT. This is the lowest level at which the patient can correctly repeat 50% of the spondaic words presented.
Spondaic words being two-syllable words like hot dog or iceberg, which are very easily recognized.
The power of the SRT is that it should agree very closely with the pure tone average, the PTA. For flat or sloping losses, we compare it to the PTA of 500, 1000, and 2000 Hz. If the SRT and the PTA are within plus or minus 10 dBs of each other, the audiogram is considered highly reliable and valid.
And if there's a significant disagreement, say, the PTA is 30 dB HL, but the SRT is 55 dB HL, we immediately suspect inconsistent effort or pseudohypoacusis.
Immediately. The relationship between those two measures is an essential checkpoint, especially when you're testing children or non-cooperative listeners.
We also compare PT results to word recognition scores, or WRS. These are suprathreshold tests that quantify the clarity or the distortion caused by a sensory neural loss. You present a list of single-syllable words at a comfortably loud level, and you measure how many the patient gets right.
For a patient with, say, a mild cochlear loss, if you amplify the signal enough to overcome the attenuation shown by their PTA, they should still score very highly on WRS. The distortion shouldn't be too bad.
But the crucial diagnostic discrepancy arises when a patient has an abnormally low WRS for a given relatively good PTA. And this is the moment where the PT test points a finger at specific retrocochlear or inner ear issues.
This discrepancy can flag very serious problems.
Yeah.
Acoustic tumors, multiple sclerosis, or significantly cochlear dead regions.
Okay, let's elaborate on dead regions. What exactly is happening in the inner ear that confuses the test?
A dead region is an area of the basilar membrane where the inner hair cells are permanently destroyed. They're no longer functional. So when we test that specific frequency, say 3000 Hz, that dead region cannot respond. However, the tone might be so loud that it leaks or it spreads to an adjacent healthier region of the cochlea, say the 4000 Hz area.
So the adjacent healthier cells respond, making the patient hear the sound and report a threshold that is artificially better than the true capability of that damaged region. The pure tone test is basically fooled into thinking the area is still functional.
That's exactly right. But when you test speech, that dead region contributes significantly to distortion, and the WRS plummets. The low WRS compared to the better-than-expected PT threshold is the critical clue that informs the clinician that they need to employ more advanced diagnostic techniques to figure this out.
Looking to the future, we have seen some major advancements in automation in audiometry.
Historically, automated audiometry started with the Beadsea audiometer back in the 1960s. That system worked on a constant frequency sweep, where the patient held a button to decrease the tone and released it to increase the tone, effectively tracing their own threshold.
And the resulting patterns, the sustained tone versus the interrupted tone tracings, were used to help differentiate certain etiologies.
Today, the systems are much more advanced. Modern automated audiometers use computer-based rules to mimic the Hewson-Westlake procedure. They can measure mask, AC, and BC thresholds, and even WRS.
And the clinical utility here is immense.
It is. It standardizes the test, it eliminates tester bias, and it improves efficiency. The goal is not to replace the audiologist, but to automate the routine cases, freeing up the professional to focus their expertise on the complex cases, on detailed counseling, or on working with difficult-to-test populations like very young children or those with complex neurological issues.
Finally, we have to place the pure tone test in the context of the complete audiologic test battery. As we mentioned, clinical protocols vary. Some start with admittance testing, which measures middle ear function. Others might skip BC if AC is normal, just to save time.
But regardless of the sequence, the pure tone evaluation remains the absolute foundational element. It is the precise, frequency-specific map that dictates the necessary gain for hearing aids, that highlights the specific pathology, and that validates every other objective and subjective measure we obtain.
We began this deep dive with the simple beep of a school screening, and we ended with the recognition that the pure tone evaluation is really a masterpiece of applied science. We moved from the confusing nuance of decibels, SPL versus HL, to the precise choreography of the Hewson-Westlake procedure, controlling response bias to accurately define that threshold.
We've seen how this simple test can isolate mechanical conductive loss from sensory neural damage, and how complex disease states, from NIHL to acoustic tumors, leave these telltale, recognizable fingerprints on the audiogram. The frequency specificity inherent in pure tone testing is, and this is the key, irreplaceable for accurate diagnosis.
The margin for error is small, and the consequences of imprecision are large. If the baseline is wrong, everything that follows, monitoring noise exposure, prescribing amplification, is flawed from the start.
Which leaves us with this final provocative thought. Considering the known inherent test-retest variability of PT thresholds, what is the fundamental threat to the quality of a major, decade-long hearing conservation program if the tester chooses not to make multiple estimates of the baseline audiogram?
If you accept a single, potentially variable threshold as the absolute starting point, every subsequent year you test that employee, you are compounding that initial variability. A baseline that's 10 dBGs too high might mask a true threshold shift for years, leading to delayed intervention and preventable long-term disability. It just underscores the precision that is required at every single step of this process.
Thank you for joining us on this detailed exploration of the pure tone evaluation. We hope you now understand that that single beep is really the gateway to a lifetime of hearing health.